preparations. ठीक है? चलें. Thank you. Okay, our today's topic is insulin preparations, right? And I think all of you know about the importance of insulin. And insulin is released from the beta cells of the islet of Langerhans in the pancreas. And when there is release of insulin, this is important question, right? When there is hyperglycemia, that means increase blood glucose level. In response to this increase blood glucose level, that is labeled as hyperglycemic state, insulin is released from the beta cells. So this insulin is going to normalize excessive blood glucose level. Clear? So there are two problems that can occur. Number one, if there is complete destruction of beta cells, what will happen? There is absolute lacking of insulin, absolute deficiency of insulin. So in that situation, we'll have to administer insulin exogenously to control the increased blood glucose level, right? And second problem that can occur related to insulin release is beta cells are intact, but one of the problem can be release insufficient amount of insulin in response to high glucose level, right? And number two important point is that insulin release is normal, but the utilization of insulin or insulin action on the side of the receptor, that is not efficient. It shows the insulin resistance. Clear? So that is why if there is absolute lacking of insulin or deficiency of insulin, a problem that can occur is labeled as diabetes or diabetes mellitus. This is the condition, right? So diabetes is basically, or diabetes mellitus is a group of diseases. Why we label as group of diseases? Because of the persistent high level of glucose. It can affect different organs of the body, right? So that is why it's a group of diseases characterized by high levels of blood glucose resulting from defect in this, already we have discussed, either insulin production, number two, insulin action, or both, right? So decreased production or absolute lacking of insulin production. And the second point that already we have discussed, the insulin resistance, that insulin is going to bind with receptors and not acting efficiently or properly, because insulin is bind first with insulin receptors, then internalization of excessive glucose molecule from outside to inside, right? So characterized by chronic hyperglycemia, and already we have discussed increased blood glucose level is labeled as hyperglycemic state. And what will happen? This hyperglycemic state with disturbances of carbohydrate, fat, and protein metabolism. So what is the difference between, because these two terms you must know before discussing the different insulin preparations that we can use as a drug, right? One of the term is basal insulin, and the second term is the prandial insulin. Prandial insulin means related to food, related to meal. Optimal levels of blood sugars pre-prandial around 110 milligram per deciliter. That means fasting blood sugar level, right? Before meal, right? So that could be labeled as the fasting blood glucose level, that is also labeled as preprandial blood glucose level, that is around 110 milligram per deciliter. And postprandial, the other is the post meal or after food, 180 milligram per deciliter. The basal or bolus insulin concept, right? So basal insulin suppresses glucose production between meals and overnight, because we are required the constant monitoring of blood glucose level, right? So that will occur related to basal insulin. So suppresses glucose production between meals and overnight, where there is no need to release insulin, right? Because if insulin is released between meal and overnight, what will happen? It will be, because it has the mechanism to internalize glucose molecule, so it will lead to a condition that is hypoglycemia, right? So low level of blood glucose. Clear? So that will be monitored with the help of this basal insulin. 40 to 50% of daily needs. This is important, right? Ideal basal insulin doesn't have a peak of activity because it is required the persistent effect, but has a smooth metabolic effect. The second is the bolus insulin, that is mealtime insulin, because whenever we start taking meals or food or whatever we are going to eat, right? So it will stimulate the release of insulin from the beta cells, surge of insulin release, right? So it will limits hyperglycemia after meals, immediate rise and sharp peak at 1 hour, and 10 to 20% of total daily insulin requirement at each meal time. Why this concept is very much important? Because you will see that the preparations that we use to control the glucose level, sometimes we have the mixed preparation. So one of the insulin preparation act as bolus insulin, and another preparation act as basal insulin to control the constant level of normal glucose level. Okay. Criteria for a diagnosis of diabetes mellitus: symptoms of diabetes plus casual plasma glucose level less than or equal to 200 milligram per deciliter. And this test can be labeled as the random blood glucose level, right? RBS. So random blood sugar, this is one of the tests. Or fasting plasma glucose higher than or equal to 126 milligram per deciliter. Suppose already we have discussed in the previous slide that normally fasting sugar level is 110, 100 to 110. Suppose if we have advised the fasting glucose level and the value is around 120 or 122, so we are going to label that patient as diabetic patient? No, right? If a patient having blood glucose level 126 or more than 126 milligram per deciliter, then we can label as that patient as diabetic patient, right? But if the blood glucose level is less than 126 milligram per deciliter, so we can label that patient as pre-diabetic patient. So in that situation, why it is important to know this? Because if patient is pre-diabetic, that means more than 110 but less than 126, right, doesn't require drug treatment. So what we are going to advise, that you may have diabetes in your future, so please take regular exercise and control your diet, right? So we'll have to convince that you change the lifestyle, modify the lifestyle in which regular exercise is mandatory, right? But if a patient having blood glucose level more than 126 milligram per deciliter, so now we can label that patient as diabetic patient. Now that patient is required the treatment. Or there is another test to our post-load glucose level higher than or equal to 200 milligram per deciliter during an oral glucose tolerance test, right? And usually this test is performed in our clinical setup to rule out gestational diabetes, right? So diabetes that can occur during pregnancy. This is important one. So this test we usually offer in to exclude the gestational diabetes. That means to exclude diabetes during pregnancy. So impaired glucose tolerance test. If the fasting plasma glucose is less than 110 milligram per deciliter, that means normal fasting glucose. If the fasting plasma glucose level is more than 110 milligram per less than 126 milligram per deciliter, that can be labeled as the impaired fasting glucose. And this point already we have discussed. Now this patient can be labeled as the pre-diabetic patient, but in this situation we are not required the treatment. But if the fasting plasma glucose level is more than 126 milligram per deciliter, so provisional diagnosis of diabetes mellitus. So this is important. There is another test that nowadays we perform, we advise, that is the hemoglobin A1C. It is a test that allows healthcare providers to see how diabetics have managed their blood glucose level over the last 2 to 3 months. Now there are two types, type 1 diabetes, type 2 diabetes, and these are the common types. But there is another type that already we have discussed, and that is the gestational diabetes, right? And this is another type that is being nowadays common, right, in our community. So before discussing this type 1 diabetes or type 2 diabetes, the point that already we have discussed, insulin is released from the beta cells of the islet of Langerhans of the pancreas in response to high blood glucose level or in response to hyperglycemic state to normalize the excessive blood glucose level, right? So insulin is released and it's going to bind with its receptor, and that receptor of which type, that is the transmembrane receptor. Because already this point already we have discussed what are the different locations of receptors, right? So again and again we have discussed this. Some of the receptors are located on the cell membrane, and the second location is the transmembrane, and the third location inside the cytoplasm, and the fourth location in the nucleus. That already we have discussed in the previous class, that corticosteroids, how they are going to produce its activity when it will reaches the nucleus, and it will bind with these specific receptors for producing activity which are located in nucleus. In case of this insulin activity, the receptor is transmembrane receptor. What does it mean? Because insulin receptor have two component, alpha component and beta component. Alpha component is located outside, and the beta component located inside. When insulin is attached with the alpha part of this transmembrane receptor, there is conformational change which take place inside, because inside there is tyrosine kinase and which is phosphorylated, and then what will happen, the internalization of glucose molecule from outside to inside of the cell. Clear? Okay. So now two problem. One of the problem is absolute lacking of insulin. What does it mean? Absolute lack. That means there is no even slight release of insulin in response to hyperglycemic state. And normally when this happens, Normally, this happen due to autoimmune destruction of beta cells, right? Autoimmune disease, and sometimes due to viral infection, right? So it's going to destroy the beta cells. So what will happen? What will happen now? Absolute lacking of insulin due to destruction of beta cell. Now this patient is totally dependent on exogenous insulin. That means we'll have to administer insulin exogenously from outside in the form of drug, in the form of insulin preparation, right? Because if there is absolute lacking of insulin, and if that patient is going to take food, so after taking food there is increase level of glucose level. Normally what happens? In response to increased blood glucose level after taking meal, there is a surge of insulin release. There is a bolus release of insulin. But now in this patient, this is not going to occur. So this patient is totally dependent on exogenous insulin. So that is why this type 1 diabetes is also called, also labeled as insulin dependent diabetes mellitus. In type 2, in type 2 what happens? There is uh, a deficiency of insulin release. That means insulin is being released but not in the normal amount, right? And second problem that can occur in type 2 is that insulin release is normal, but the action of insulin is not proper. That means insulin is showing the resistance, right? Due to uh, uh, receptor binding mechanism that is not proper, right? So there is no proper utilization of glucose from outside to inside the cell, right? So these are the two mechanisms that can occur in type 2. So because in type 2 there is some release of insulin, or there is normal release but there is no proper utilization of glucose in response to insulin, that is non-insulin dependent diabetes mellitus, right? And the third type that already we have discussed, that is the gestational diabetes. During pregnancies, some female may show persistent high blood glucose level. So, type 1 diabetes, now this is the explanation, the point already we have discussed. Lack of insulin production or production of defective insulin. Affected patients need exogenous insulin, right? So, complications that can occur: diabetic ketoacidosis and hyperosmolar non ketotic syndrome. Oral anti-diabetic drugs not effective. So the patient who are totally dependent on exogenous insulin, oral anti-diabetic drugs not effective. Why? The simple explanation: because oral drugs, they are going to enhance the release of insulin. That means if beta cells, some of the beta cells are intact, then oral anti-diabetic drugs can show the effect or result. But if there is absolute lacking due to destruction of beta cell, there is no function intact of beta cells, the use of oral anti-diabetic drug would be ineffective. So in type 1, what are the signs and symptoms? Polyuria, right? Polydipsia, that is the thirst, increased thirst. Polyphagia, increased hunger. Weight loss, fatigue, increased frequency of infection, right? Rapid onset, insulin dependent, right? Familial tendency, peak incidence from 10 to 15 years, right? Type 2, most common type, and caused by insulin deficiency and insulin resistance. This concept already we have discussed, because this is the important concept that you must know. Insulin deficiency, that means insulin is released but not in a proper amount or normal amount. And number second, insulin release is normal, but the insulin function is not proper, showing the resistance, right? So many tissues are resistant to insulin, like reduce number of insulin receptors. This is one of the reason of improper action of insulin, that label as the insulin resistance. Insulin receptors less responsive, and these people respond to oral hypoglycemics. Type 2 sign and symptoms: sedentary lifestyle, familial tendency, average age 50 years. But one important point, it can also occur in young adults as well. But normally, its average age is of 50 years, but this is not the absolute indication for type 2 diabetes, right? History of increased blood pressure, fatigue, and decreased energy, obese. This is one of the important factor of type 2 diabetes. Recurrent infections, polyuria, polydipsia, and fasting blood sugar that is more than 126 milligram per deciliter. Treatment differences, as already we have discussed, type 1, that is also called insulin dependent diabetes, and that means absolute uh, lacking of insulin. So a patient is totally dependent on exogenous insulin, and as well as dietary control, right? That is required. And type 2, first of all, lifestyle changes, right? Dietary changes, exercise, exercise habits, clear. In type 2, insulin, when oral hypoglycemic medications can no longer provide glycemic control. Clear? Okay. Now, insulin. Insulin mechanism of action, it's substitute for and same effects as endogenous insulin. Restore the diabetic patient's ability to metabolize carbohydrate, fats, and proteins, and store glucose in the liver, and convert glycogen to fat stores, and some derive from porcine sources. That means we can derive from the pig source, pig. There are two animal derivatives from which we can prepare insulin preparation: bovine and porcine. Bovine, that is the beef, and porcine, that is from the pig. But bovine insulin preparation maximally show the antigenicity. That means allergic reactions are maximum. Allergic reactions are minimum if we are using pig drive insulin preparation. But nowadays, we are using human insulin preparation, right? So human insulin's structure is modified, and we are using recombinant DNA technologies. So nowadays, in our clinical setup, we are using human insulin because least chances of allergic reactions, least antigenicity, right? So these insulin that will show the tight glucose control. So that is why sometimes if there is a plan for the surgery in a patient who doesn't have control blood glucose level, and that patient is already taking oral anti-diabetic drug. So in that situation, to perform surgery, before performing the surgery, we can use insulin preparation to control the glucose level, and then we are going to perform the surgery, right? So what is the purpose of controlling blood glucose level, right? Or euglycemic state, that means the normal blood glucose level, to control the long-term complications that can occur, right? So macrovascular complication or microvascular complications that can occur if we are not going to control the blood glucose level. Right. Another very important mechanism that occurs at the molecular level, that insulin, they are after binding. What happens when glucose is going to bind? Suppose there is excessive blood glucose level. This glucose is going to bind with beta cells and closes the potassium channel. So what will happen? Due to the closure of the potassium channel, there is process of depolarization. So depolarization, there is opening of the channels, and insulin is released from the beta cells. Now, these are the different preparations that we can use, right? Number one is the rapid acting. These are the human based insulin. And what is the importance of human based insulin? Least chances of antigenicity, least chances of allergic reactions. When we inject, what is the commonest route of insulin injection? What is the commonest route of insulin injection? Can you tell me the answer, one of you? What is the commonest route of insulin injection? Can I have the answer from one of you? Okay, the commonest route is the subcutaneous. Very good, right? So insulin, the commonest route is the subcutaneous route, but insulin can be administered intramuscularly, can be administered intravenously. But most of the insulin preparations are administered subcutaneously, because not all insulin preparation can be given intravenously. There are some insulin, like rapid onset insulin, especially the regular insulin, that can be given intravenously in emergency situation. And another question, can we give insulin orally? Can we give insulin preparation orally? No. Why? Okay, you are right. No, but why? Okay, because it's a protein polypeptide in nature. So digestive enzyme, they are going to digest this insulin structure. Because this is one of the common question that can be asked, simple question that can be asked in Viva, and some of the students they are unable to reply the answer. One of the question that is asked, the commonest route, that is the subcutaneous route, or can we give insulin orally? No, right? The reason already we have discussed. Now, one of the type is the rapid acting insulin, right? Most rapid onset of action, right? But, and this is the general concept, any drug having rapid onset of action definitely will show the shorter duration of action. And already we have discussed in the initial slides, right? Because in response to food, we are required the surge of insulin or bolus insulin release that normally occur. So if a patient is on exogenous insulin, so this rapid acting insulin will act or will do the activity just like the bolus insulin or surge of insulin release in response to food, right? But it will show the short duration of action. So there should be another insulin preparation that can maintain the in between blood glucose level in between the meal and overnight, that already we have discussed. Okay, so this rapid acting, most rapid onset of action and shorter duration. So what you must know from the exam point of view, the name, right? So what are the rapid acting insulin, right? You must know the name. One of the name is the aspart insulin, insulin lispro, and insulin glulisine, right? So onset of action is 2 to 33 minutes, and peak hours around 1 to 3. And in case of lispro, 30 minutes to 2.5 hour, and glulisine 30 minutes to 1.5 hour, right? So this is the peak activity and the duration. So it will uh, produce its activity up to 5 hours in case of aspart, and more or less in lispro 6.5 hours, and uh, 1 to 0.25, that 1.5 hour, right? So may be given subcutaneous or via continuous subcutaneous infusion pump, but not intravenously, right? Intravenously normally we use which preparation? Regular insulin, or this is another type. This is another question that is asked in the exam. Okay, which insulin preparation can be given intravenously? So your answer would be regular insulin. and regular insulin under the heading of short acting, right? So regular insulin, and these are the market name or proprietary name. If you don't remember, no problem. But regular insulin, this you must know, right? There are two types, right? Humulin R or Novolin R. So onset 30 minutes to 4 hours onset of action, and 30 minutes to uh, 30 minutes is the onset of action. What is the difference? In rapid acting, you can see around as you administer insulin and quickly uh, it will show the level in the blood. So that is where rapid onset of action, 2 minutes to 33 minutes, right? And in case of this, it usually requires the slight more times, 30 minutes, half hour is required to reach in the blood level, right? So peak hours is around 2.5 to 5 hours, and duration is around 5 to 10, right? So slight difference in Novolin, but more or less same. Humulin R or Novolin R, these are the examples of regular insulin. Clear? The only insulin product that can be given by intravenous bolus, IV infusion, or even intramuscular administration. Now, the third variety, right? So, number one variety is the rapid onset, and what I've told you from the exam point of view, you must know the name at least, right? Aspart, Lispro, Clolizine, these are the example of rapid acting. Examples of short acting is the regular insulin, right? And the third group is the intermediate acting. So one of the preparation is the isophane insulin suspension, and also called NPH, right? So neutral protamine hydron. So this is the name. So these are the market name, Humulin N, Novolin N. So if you don't know the market name, no problem at this level. So at least you must know the generic name, right? So isophane insulin suspension and insulin injection. So combinations, we usually use the combination. So Humulin 50-50, Humulin 70-30, right? So what is this Humulin, right? Humulin, this is the regular insulin. Novolin, this is the regular insulin. So we use the regular insulin with this intermediate insulin. So this is the combination, right? So combination 70-30. Lisproprotamine suspension. And what is this Lispro? You know, Lispro belongs to rapid acting, right? So this Lispro can also be used as the lisproprotamine suspension, Amalog 75-25, 70-30 combination, insulin zinc suspension, right? So different suspension, isophane insulin suspension, lisproprotamine suspension, insulin zinc suspension. And that is why, because the suspension, it showed the cloudy appearance, slower in onset and more prolonged duration than endogenous insulin. So it will show the persistent activity, right? So again, this intermediate acting, the third, isophane, right? Isophane and insulin, that is the combination, right? Isophane, humulin N, Novolin N, right? So, and isophane and insulin, that is the mixture combination. Lisproprotamine and Lispro, so again the mixed combination, right? So insulin zinc suspension, and the example is the Lenti and Novolin L. Now the long acting. So the important example and important preparation that is being used clinically, that is the insulin glargine. So this is asked in the exam. So examples of long acting insulin glargine, right? Onset is usually within 1 hour, but no peak activity. What does it means? It will show the persistent activity, right? 24 hours when administered at night time, and it is usually administered at night time. HS means hora somni, that means at night time. So second example is the detamir, and it's having the peak activity 6 to 8 hours, but duration again the up to 28 hours. So these are the different sites where we can use insulin syringe, right? So because we'll have to change the site persistently to avoid the lipodystrophy or hypertrophy. But one important point, this lipodystrophy or lipohypertrophy or hypertrophy, that is not going to occur nowadays because we are using human insulin and least chances of antigenicity reaction. So, but in the past, when we use the bovine insulin preparation or porcine insulin preparation, this is one of the common adverse effects, lipodystrophy. But with the use of human insulin preparation, now these problems are least. Insulin pump, there's external pump or internal pump, right? So one of the problem. Now this is very important because if a patient is insulin, one problem we must keep in our mind. What is that? Because excessive dose may produce hypoglycemia, because when there is internalization of excessive glucose molecule, what will happen? It will lead to hypoglycemia. So that is why dose adjustment is necessary to avoid the hypoglycemic state, because patient may go into hypoglycemic shock, right? So there are specific insulin syringes are available, and the most commonly used insulin syringe having 100 units per ml, right? So one insulin syringe is equal to 1 ml having 100 units, right? So commonly we are using this type of syringe, but also we have 200 units insulin syringe, but commonly we are using 100 units per ml syringe, right? So how we come to know that this patient may have, if a patient is on insulin, and this how we come to know that maybe this patient having hypoglycemia? So one of the term is TIRE, that means tachycardia. It will show the increased heart rate, irritability, restless, excessive hunger, diaphoresis, and depression. Diaphoresis is the excessive sweating. So tired. So this show that this patient may have hypoglycemia. So this is one of the common side effect. Now again, this is one of the another question that is asked in the exam. The commonest route, right? Which route we cannot use? What are the different insulin preparation? What are the examples of rapid acting insulin? What are the example of short acting insulin? What are the examples of intermediate insulin preparations? And what are the examples of long acting insulin preparation? Now this question, what is the common side effect of insulin? That is the hypoglycemia, right? So how we can treat this patient? So a good way to remember: blood sugar, mnemonic, hot and dry, sugar is high, and cold and clammy needs some candy. So okay, so this is one of the point. But clinically, if a patient is having hypoglycemia, how we can treat? By giving, how we can restore that glucose level. Either we give glucose preparation, right? Glucose preparation, or like chocolate and something sweet that can raise the sugar level. But in emergency, suppose if patient is unable to take all these things orally, so we can use the dextrose preparation, dextrose sugar intravenous infusion. that is called the dextrose. And suppose in emergency situation dextrose preparation is not available, so which another preparation can raise the level of glucose? This is another very important question. If suppose if you have very good viva and you are going to answer every question, then this would be the last question that can be asked to give you the maximum marks. That suppose hypoglycemia and patient is unable to take the sweets or candy or glucose orally, so you will give the IV infusion of dextrose. But suppose unfortunately dextrose infusion is not available, so with do you have any other preparation in your mind that can raise the level of glucose in emergency? Any one of you? Any one of you can give me the answer? Which preparation can increase the level of glucose? No. IV dextrose, this already we have discussed. So suppose in the emergency department, dextrose, IV dextrose is short, not available. So what you will order? Glucagon. Very good. Glucagon, right? Glucagon. So this is one of the important question, and that can be asked in the exam, right? Very nice. So thank you so much. So in tomorrow's lecture, inshallah, we are going to discuss the uh, other preparation that can be given parentally, but we are going to focus mainly on oral hypoglycemic drugs. So most of the points already we have discussed related to type 2. So we are not going to discuss it again, right? So directly. Okay, how is the insulin pump is used? When we place the pump internally, suppose subcutaneously we plant it, so that will automatically releases insulin in response to blood glucose level. But the pump that we place externally, that can be controlled manually, just to check the value, so we can pump it ourselves to release how much amount we can use to control that excessive blood glucose level, right? So that is why external pump and internal pump we have used two terms. Okay, so I think thank you very much. Inshallah, in tomorrow's class we are going to discuss oral hypoglycemic drug. Okay, ji. Thank you.
So
हेलो। जी जी जी, चलें,
चलें सर,
थैंक
ओके,
यू।
अल्लाह हाफिज़।